Well, welcome to the Aging Boomers. I'm your host, Frank Sampson. Of course, on our show, we discuss so many of the issues facing boomers, their parents, and what we know, of course, is an aging population. And I just want to, thank everybody for all their support. So many of you have been listening to our show. We're getting more and more listeners. A lot of you have downloaded our free app called The Aging Boomers, which you can do on your iPhone or Android phone. Many of you have gone on to iTunes, iHeartRadio, Spreaker, Stitcher, a lot of different online stations to just register. It's free, and keep up to date on all the interviews we're doing. So again, thank you so much for your support. Just want to remind everybody that today's show is sponsored by Senior Care Authority, a professional senior placement and elder care consulting organization that has a national network of advisors to help in determining the right path for senior living and receiving proper care. So whether you need just an advocate or you need assistance for in-home care, assisted living, residential or memory care, get the necessary advice from a senior care advisor in your area by calling Senior Care Authority at 888-809-1231, or you could go directly to the website at www.seniorcareauthority.com. Also want to thank everybody for their support on my first book called The Aging Boomers, which is a compilation of a lot of the interviews that we've done. And we're getting some great reviews on it. You could get that at Amazon. And I'm really excited about, I'm always excited about our guests, but we're going to be talking about a very important subject matter, the future of our healthcare system. And we have with us Dr. Benjamin Bensadin, who is a licensed clinical geropsychologist, associate director of the internal medicine residency programs, geriatrics and palliative care rotation, and assistant professor of clinical biomedical science in the Department of Integrated Medical Sciences at Florida Atlantic University's Charles E. Schmidt College of Medicine. In these roles, he goes by Dr. Ben. So Dr. Ben develops, implements, and evaluates training curricula in classroom and clinical settings for medical students, residents, and other health sciences trainees, works clinically in long-term care, geriatric rehabilitation, outpatient, primary care, and specialty settings, and conducts clinical and medical education research. He's also published a book, which we'll talk about as well, has other published materials and lectured nationally and internationally. So Dr. Ben, boy, I'll tell you, I got to take a little rest here after that intro. It's tremendous what you've done, and thank you so much for joining us on the Aging Boomers. Thanks for having me. Yeah, so first off, and thank you for everything that you do. I mean, it's just tremendous. Your accomplishments and your emphasis on seniors and their families. So really appreciate that. So with all this work that you've done and teaching, and probably have a fairly good understanding of what's going on in the healthcare system, does that keep you up at night? I mean, with what's going on and all the changes and the Affordable Care Act and everything that's happening, does it keep you up at night at all?
Sure, but I drink a lot of coffee as well. So
okay.
Two of those factors, yes. But I have a lot of work to do. So at least for now, it's going okay. There's a lot of uncertainty about the future. So I like to look at that as sort of there's an opportunity to try and shape it in a good way. So I think that's sort of what fuels me, at least for now.
Do you think, if we were to fast forward 10 years from now, do you think the healthcare system's going to be in better shape than it is today? Or are you concerned about its future?
Well, sort of consistent with the topic today, my focus really is elder care. Mm-hmm. And what's a challenging mission, I guess, is to try and really give older patients sort of the dignity I think they deserve in terms of healthcare from every aspect. So, will it be better as people age and live longer? It's pretty tough to tell. I'm pushing for that. I think one of the greatest challenges, certainly within medicine, is throughout the country and really the world, people are living longer, and they're also living sicker. So chronic disease is sort of blanketing the world, certainly our nation, but the traditional models of training and care have tended to be more acute and hospital-based. So trying to help manage people with their chronic diseases that are not curable has not, it's tough to do that, and has not been the focus generally, but hopefully we can shift a bit to make that better. So I have optimism for that, for sure.
So talk to us about, it's a term we hear, I hear quite often, and I have a general understanding what's meant by it, but talk to us about this term called integrated care. What tell us more what that means.
Sure. Well, again, I think even that, it's still unknown what that will look like. The way I conceive of it, and I made sort of the subtitle of my book, Integrated Care for an Aging Population, has to do with who's providing the care. And I think what disciplines are sort of accessible. And as you mentioned in the intro, I'm trained as a psychologist, and the focus is behavior. And I think, and what I'm sort of advocating for is better attention to and expertise in managing behavior, which will translate into better outcomes for everyone. For example, people with chronic disease, they have to often, manage it on their own. Self-management, that's sort of the name of the game, certainly in the United States, with periodic follow-ups from clinicians, physicians, nurses, and so on. So to do that requires a lot of psychological strength to be motivated to, let's say, take your medication on a regular basis, to exercise, to watch your diet, to feel confident that you can actually manage your symptoms depending on how intense they are on a particular day, because those can fluctuate, and you may never know when you're going to feel better or worse by the day. That can take a major toll, and it's hard to do that, but that's a lot of behavioral sort of expertise that could help with that. So part of me says, putting in experts on behavior, recognizing when mood is low, which is then impacting motivation, which is then impacting exercise or diet or medication adherence, major problems in the country, could be helpful. So when I think of integrated care, I think at least there's a behavioral component, psychosocial component, as well as a biomedical component. Now, the government is also starting to talk about that. Specifically, in primary care, for example, there's a push to some degree to focus on what's now called behavioral health. There are a lot of terms that sort of emerge, but I think they're essentially looking at the same thing. So putting behavioral health into primary care, integrating the two, I think that's also a big push, not just from the government, but some of the larger groups representing, including physicians, such as the American College of Physicians. There are position statements being published about the need for better integration of behavioral health in primary care. The Institute of Medicine actually came out with a report recently of several hundred pages advocating for better integration of psychosocial interventions and basically raising a long-time question, which is, in spite of a good evidence base, these things are not implemented in routine practice, and that really needs to change to improve care. So in terms of integration, that's sort of what I think about and what it seems to be the country's thinking about.
Yeah. I have to bring up, kind of the part of the industry that I'm involved in, and tell me your thoughts on this. I see, as I'm sure you have, gone into many skilled nursing facilities. Sometimes there's called nursing homes, skilled nursing facilities, rehab, a lot of different names. But I see, many times people in these skilled nursing facilities that don't have to be there. They just, and again, I'm not a professional like you from a medical standpoint, but it's just so obvious they don't have to be there. But they're there because the government is paying for them to be there, yet maybe they could be in a more of an environment like assisted living, and the problem is that in that case, it's the consumer would have to foot the bill. Do you see that changing? Is that a conflict that you run into quite often?
Well, that's a great point. I think the last piece of that, footing the bill, is very relevant, especially because your show is called The Aging Boomers. The baby boom generation, one of the things that I think distinguishes it from prior cohorts of the elderly is affluence, comparatively speaking. So over time, this group of people, of seniors, will be a bit wealthier, and what they will do with that, will vary. But I think, assisted living as a concept, to maintain independence, just have some support as needed, is a great model. And I think when it originated, it was quite different from, let's say, the nursing home or nursing level care in terms of independence and focus on autonomy of the person. But I think increasingly that has been changing, and the two are getting closer together, and that's driven by a myriad of factors, including liability and a focus on safety and many other things that make it challenging. I would share, there's a wonderful book called Being Mortal, written by Atul Gawande, who's a Harvard surgeon, and he talks about his father, who also was a physician, and how they navigated the end-of-life spectrum. And they get into the difference between assisted living and nursing homes, and I think they even mention sort of some of the real ethical challenges when people age. For example, if someone has a cognitive impairment, but they're still interested in being autonomous, can you allow them, let's say, to live on their own, with their own kitchen, allow them to cook, and try and preserve quality of life, even though that may add a risk of, let's say, forgetting that they're cooking something and a fire could start, and there could be dangers associated with that. Or even more, perhaps a bit radical seeming, if someone is a fall risk, but they don't want to be in a wheelchair and they want to keep moving, do you put a helmet on them and allow them to try and be independent still, even if they may fall? These are really hard questions, and they're not talked about that much, but I think this gets into autonomy, independence, quality of life, and even the distinction you're talking about between sort of nursing level care where supervision is there and safety is sort of the focus versus more independent, assisted living, focus on quality of life.
Right. So tell me if I'm correct, because I don't have any real statistics, it's just people that I talk with, that there's not enough doctors specializing in geriatrics. I love to know what incentivized you to get involved in this field, but do you think that there is a need as we move forward with the boomers aging and the silver tsunami that's coming about, do we have enough physicians specializing in this field?
So I'm glad you asked that. This is a really challenging question. The fight to demonstrate sort of legitimacy as a bona fide subspecialty for geriatric medicine has lasted decades and continues to this day. And bluntly, as people age and live longer and the older demographic increases now at an unprecedented rate, the supply of certainly board-certified geriatricians is decreasing. There are a lot of reasons for that. For example, the reimbursement system in the United States is primarily focused on procedures, and for many reasons, with older patients, fewer procedures are performed. Thus, income goes down for, let's say, someone focused on being a geriatrician. Another example is the glamour is not necessarily associated with geriatrics because that's primarily management, not really focused on cure. And a lot of new physicians or physicians in training are the allure of going into medicine is to be able to cure people, quote unquote, save people, and see sort of the result pretty fast. Management, which is much longer and more of a supportive role, I think, has not been necessarily the glamorous part in most eyes of learners in medicine. So they seek other kinds of specialization. So the supply is going down, the need is going up. There's also another, I think, factor that I've certainly focused on because I am a clinical geropsychologist, which is the psychological, meaning aging for most of us is personally relevant. Now, for me, that's why I chose it. I mean, in part I was raised by my grandmother, so from an early age I developed an affinity for the older person and a deep respect for them, and this is something I could give my life to. Not everybody has that experience, but the fact is, improving elder care will help all of us. It's just a matter of time. And I think, unfortunately or ironically, one of the best ways people cope with sort of the limited duration of life is by sort of avoiding or pretending it's not really limited. And many of us don't want to look at what we will look like in 30, 40, 50 years. And if you're working with an elder population, you see that every day, and some of the challenges that aging brings, and infirmity that aging brings, so people don't necessarily like to go there. This is not new. This is decades old and sort of inherent to the human condition, but it's really playing out. So all these sort of factors combined, I think, shed light on why aging in geriatrics is not that popular. But at least in my lifetime, I'm committed to trying to help sell it, because it's, to me, certainly one of the most rewarding areas to focus on.
So do you see some of your peers in this field got into it because of personal experience, or they just see the need?
Well, I think in general, people make most of their choices based on personal experience. I think pretty much everything is personal, and when I teach or do the trainings, I try and focus on that. So I try and get to know a little bit about whoever I'm teaching before I go further, and try and tailor whatever the messages I'm trying to convey to them, because I think the more personal they feel it, the better, and the more effective it will be. So I would point out, interestingly enough, when I talked about financial reimbursement and economics, there are data showing that geriatrics has been either the top or among the top subspecialties or specialties in medicine in terms of physician satisfaction. So the question becomes, how is that? Because it's also inversely proportional to the reimbursement. So while there's a lot of discussion about financial incentives, it seems to be there are other incentives that drive this, because that's played out a couple times.
Right. Yeah, good point. Speaking about your teaching, so I'm curious, and the question I'm going to ask you could probably spend all day answering, so obviously want to get kind of an overview, but the curricula itself, how is it different today in teaching medical students versus, let's say, even 10 years ago? Is it quite different?
Sure. Yes, much has been made about the so-called millennial generation and how they require a different teaching style. I'm not really sure where I stand on that, because most generations are somewhat unique for a lot of reasons. There is a bit more of a push toward a student-centered or learner-centered approach, where it's much less pedantic or certainly paternalistic, where you try and include the learner in their own learning, and there's the notion of self-directed learning as well. But the focus on communication, for example, be it at end of life or about touchy subjects, I mentioned certainly in my book, like driving and trying to counsel people that they may need to stop driving and so on. That's all relatively new, I think. There's been an expansion away from strictly more biomedical science focus. So there's a lot, slow, but there's a lot of focus on behavioral aspects now, at least compared to in the past. So I think that's promising.
You hear so often about how's a particular doctor's bedside manner, and is there an emphasis on that as well within the curriculum today?
Sure, that's a great point. The bedside manner. I think even in the late 1800s, that was known to be inseparable from quality care. The question becomes, how do you teach that? Again, I would strip that down as focusing on the communication, which is a measurable, teachable, learnable skill set. There are some challenges in how to define these things. I think there are now core competencies developed and defined by accrediting bodies that suggest, okay, to be accredited, the learner needs to demonstrate competency in X. And some of those, I think, are clearer than others. For example, professionalism has become an actual competency. I'm not sure that's a great idea, because professionalism is hard to define and hard to measure, and it can be perceived as sort of a personal characteristic as opposed to an actual skill set. Conversely, communication, as I mentioned earlier, that can be measured and taught, and certainly in our training, we videotape the learner, and then we watch it and break it down and show, including nonverbal communication, what they did, they didn't do, how it went, reaction by the patient, by the family, often who are actually actors. We use a lot of acting, older people as standardized patients, that's the term. So that's a bit, I think, easier to quantify, measure, teach, and so on. But the bedside manner, I think, is always going to be there. And unfortunately, in actual medical practice, certainly in hospitals, there's less and less time, as well as in office visits, to develop the relationship. And I think many, it's pretty well known, many physicians for sure, but other clinicians as well, they're not pleased with that, and that is driving burnout, because the relational aspects of medical care with patients, with families, are sort of being thrown away. And that's driving burnout, and burnout among clinicians is well documented. And there have been studies showing burnout leads to substance use, it leads to depression, it leads to other things that are very sort of deleterious consequences. So I think clinicians need support, and I think to date that has not been provided. And the challenges of that are often reflected even in actually the bedside manner, because people are exhausted, frustrated, and unsupported, and I think you can't separate those.
Do you think, speaking about the boomers, and I'd like you to spend just a couple minutes on this, I want to leave some time to talk about your book and a lot of the issues that you raise in your book. But before we get to that, the boomers themselves, the aging boomers, I mean, and again, I know it's different in every case, but generally speaking, working with an 85-year-old person today, do you feel that's going to be quite different than dealing with that 85-year-old boomer as it relates to just, or is it going to be pretty much the same? I mean, I would hope, at least I would hope, that boomers maybe take better care of themselves. At least I hope so. But what's your feeling on that?
Sure, and some of this will depend, I think, on socioeconomic status, because we have a tendency to try and group people together, which is just normal and natural, but it's often deceptive. So even sort of what is an older person, we don't really have an age cutoff for that, because people age at different rates. So even boomers, which relates to a certain cohort based on when they were born, there's a lot of diversity and heterogeneity there. Having said that, when you mention taking care of themselves, so exercise, the benefits of exercise, I think, have been sort of pushed more recently. So while that seems to be positive, let's say from a cardiovascular standpoint, there are probably more and more joint replacements, for example, joint surgeries than ever before due to that. Or, for example, older people do a lot of research now. The internet has emerged, and people do their homework as far as what a problem is, who can treat it, where they should go, what can they do on their own. And they want to stay active and be autonomous. I think that's also somewhat relevant to the cohort. And in terms of healthcare, prior cohorts of patients or older people, I believe, were a bit more sort of obedient to authority and would sort of let the clinician, the physician, try and dictate sort of how things go, and they would go along with it pretty stoically. This is a bit different now with the booming generation, where they want to be more involved, engaged, and sort of partnering with the clinicians in their care. And that's actually spawned a phrase called shared decision-making as sort of the model away from what has been called paternalism. And there's mixed views about both of those, but I think engaging the older patient in the newer cohorts, the boomers, for example, is a bit different than in the past, when it was more about, here's what you need to do, I'll tell you what to do, now you have to go do that.
Yeah, it's certainly interesting. I mean, I interviewed a woman not too long ago. She's a physical therapist and specializes in working with older adults. When you talked about, I think older, if they're going to exercise, they go on walks, all right? And I asked her, I said, would you rather see somebody, at least I'm talking people in their 70s, 80s, going on walks or doing some other sort of exercise? And she said, it's leg strengthening. that's the most important thing for an older adult is leg strengthening. Helping, doing it in a certain way to help reduce chances of falls and all of that. She felt that that's more important than anything. I don't know what your thoughts are on that, but she seemed to be pretty sure of herself that that's the case. She deals with it
Sure.
each and every day. And
Sure.
and based on what you said, with you're seeing we're seeing so much joint replacement now than we used to. Obviously, it's maybe that the ability to do it in a proper way years ago wasn't there, but today it is. So I don't know which it is that people didn't prepare well in keeping their legs strong and hips strong and all that, or what. So I don't know if you have any thoughts on that at all.
Sure. Like lower body strength is very important. Falls can be a big problem, and they can lead to a cascade of events that many people are familiar with, even personally, from which some never recover. So it's hard to sort of plan for a fall and prevent against the fall, though falls prevention is a focus. So leg strength, balance, and gait is crucial. Sure.
Yeah.
But I'm not sure it's a matter of this was not addressed in the past. Again, the sort of focus on well-being, exercise, being active, I think, has increased over time, and people now are really going right into it and trying to stay active as long as possible.
Right. So, Dr. Ben, tell us, we've got a couple minutes here, but I want to make sure we get in. Tell us about your book and just some of the issues that you bring up, which are very important, more taboo-type issues like suicide, incontinence, dementia, areas people don't really like talking about. All right, tell us a little bit more about it, and also tell our listeners how they can get the book.
Sure. Let me lead with the last thing you said. The book is online, Amazon, everywhere else. It's called Psychology and Geriatrics: Integrated Care for an Aging Population. It's sort of a hybrid. It's part textbook, part professional resource, but I hope the language is simple enough for most people to be able to follow. And the topics of the chapters are sort of, each one is sort of an elephant in the room. For example, I'm in South Florida, where we have a lot of older people, which most people have heard of, and driving can be a challenge. So there's a topic on driving written by two psychologists and a neurologist who actually co-wrote the AMA guidelines for driving assessment of cognitively impaired persons. Now, driving is something that's very hard to talk about, and there's a lot of fear in raising it, fear that it will actually damage the relationship with patients and families and sort of the independence that goes with driving and other things. So what happens is it gets avoided, sometimes until it's too late. So driving is one of the, driving assessment, so on, is one of the chapters. End of life care, which is extremely relevant now as people live longer and sicker and so on, and we really see the limitations of biomedical intervention. So the Institute of Medicine in 2014 put together a 600-plus page report. My book is shorter than that, I'll point out, on dying in America. That's actually the title. So there's a chapter looking at that and trying to challenge the notion, often pushed by media, that death is optional, because it's not. So we need to really grasp and think about that. There's another chapter on suicide prevention. Suicide rates have been highest in the older demographic for decades. And again, multiple reasons for that, but certainly I'm pretty passionate about trying to help us pay more attention to subtleties that can clue us in on distress that we can then try and manage to prevent some of this from happening. And that's written, again, by a geropsychologist who focuses on suicide and a primary care provider that he works with. So I think those are some examples of sort of the touchy subjects that really need to be addressed. And again, you ask about sort of training. What I'm most sort of enthused about now is certainly in the culture of medicine and medical training, there's a bit more openness to addressing things that in the past were just avoided. One of the greatest differences between doctoral training in medicine and doctoral training in psychology is when we train as psychologists, we're forced to focus on things that make us uncomfortable, and then we talk about why. in medical training that has not been the model, and with sort of power, you are able to sort of avoid or not focus much on stuff that's very emotionally uncomfortable. And I think, quite honestly, when that changes, care will improve.
All right, well, we'll leave it with that. I could talk to you all day about this subject matter. But again, before we sign off, just tell people again the name of your book, and I know they could get it on Amazon, but go ahead and repeat the name again.
Sure. Psychology and Geriatrics, Integrated Care for an Aging Population.
Great. Dr. Benjamin Bensadin, thank you so much for joining us. You've been a wealth of information. There's so much to talk about, certainly in the future on what's going on. So love to have you back. Hopefully you'll join us in the future on so many other subject matters as well.
Thanks.
Yeah, and I want to thank everybody for joining us on the Aging Boomers. Just be safe out there, and we'll talk to y'all soon.